So we're going to conclude the session with two additional talks from a surgery perspective, although to make that transition, Dr. Jagsy certainly gave me some more ammunition about prostate cosmesis as I try to steer patients away from radiation towards surgery. Next speaker, I'd like to introduce Dr. Wright as head of GYN oncology at Columbia. We're very fortunate to have him speak today. He's been the foremost authority in terms of looking at unintended consequences of adoption of new technologies in his field, and I've gotten to know him through the NYP hospital system. So without further ado, Jason, please.
Thanks, Jim. I'd like to thank the organizing committee, Jim and Ted, for the opportunity to present today. As Jim said, we'll turn our attention now a little bit to some more surgical talks. And my talk is entitled Adoption of Robotic and New Technology in Gynecologic Oncology. So just in the way of overview, I'll really cover two procedures today. Since we spent most of the morning beating up on the robot, I'll only spend about half of the talk talking about robotic-assisted surgery and GYN, and then spend the remainder of the talk on electric power morcellation, which has been quite prominently featured in the national news, both the Wall Street Journal and the New York Times. So just a little in the way of background about hysterectomy. Hysterectomy is one of the most common procedures in women in the United States. 600,000 procedures annually in the U.S. So this is second only to cesarean section in terms of absolute numbers for surgical procedures. You can see the statistics. Ultimately, 1 in 9 women during their lifetime will undergo a hysterectomy. The vast majority of hysterectomies are performed for benign indications or precancerous changes, cervical dysplasia, endometrial hyperplasia, with around 10% of hysterectomies performed for malignant indications, either cervical cancer, uterine cancer, or ovarian cancer. Now, hysterectomy, the different routes of hysterectomy have been around for a long time. So for the last 100 years, people have been performing abdominal and vaginal hysterectomies. You can see on the figure here that the classic approach to hysterectomy is what's called an abdominal hysterectomy or a laparotomy, where there's either a large midline abdominal incision or a low transverse incision. This is really the classic operation for GYN cancer surgery. Vaginal hysterectomy has also been long described as a route of hysterectomy where the uterus is removed through the vagina. Now, the obvious benefits of this are there are no surgical incisions on the abdomen, so the recovery of all the techniques that are available is the best, but this tends to be a fairly niched procedure for pelvic organ prolapse and really isn't a cancer operation. More recently, there's been much more interest in minimally invasive surgical techniques, both laparoscopic and robotic surgery. You can see the typical setup for the incisions for a laparoscopic hysterectomy, typically 4 small incisions on the abdomen. Laparoscopic hysterectomy has been a procedure that's now been around for 25 years. The first laparoscopic hysterectomy was performed in the early 1990s. This is something that's now routinely taught in OB/GYN residency programs and widespread practice by community physicians. So this is not a highly specialized procedure that's only performed by a handful of physicians. Most recently, there's been the introduction of robotic surgical technology. And you can see the typical setup for a robotic hysterectomy. Typically, actually, more ports than a hysterectomy are required, and typically the incisions on the abdominal wall are a little bit larger for those than we would use for a typical laparoscopic hysterectomy. You can see the typical setup, and again, I think you saw a slide like this or similar to this morning for robotic-assisted surgery, where you have a surgeon who sits at a remote console and essentially controls instrumentation that's at the patient's bedside. The bedside instrumentation is often manipulated by their surgical assistant, a resident or fellow in training. And there have been a number of benefits that have been purported for robotic surgery. Improved 3D visualization, increased range of motion of the instrumentation. You saw the nice video of suturing robotically this morning. Enhanced surgeon ergonomics for an endometrial cancer procedure. A laparoscopic hysterectomy is often a 4 to 4.5 hour procedure, so the ergonomics are certainly enhanced if you're sitting at a console, and it improves surgeon fatigue. And the big selling point in gynecologic surgery is that the availability of robotics may allow for the completion of more technically challenging cases by a minimally invasive approach. And I think this is really a key point. When we talked this morning about prostatectomy, when you look at the landscape of radical prostatectomy, really the choices are between a robotic procedure or an open procedure. I think for many operations, which you heard from Dr. Whalen for colon cancer, as well as for GYN, there's already a minimally invasive option that's out there with laparoscopy that's been fairly well vetted. When robots started to diffuse into GYN care and GYN cancer care was in the around 2009 or 2010. And this is once the technology was already available in hospitals. The urologic surgeons were the predominant users of the procedure and the technology at that time. And it began to diffuse into the GYN world around the late 2008, 2009 time period. And at that time, there was really minimal data on the use of robotic surgery. When you look at the development of laparoscopic surgery for endometrial cancer, diffusion was slow, but there were ultimately randomized controlled trials performed by the GOG in the US, data from Australia that was randomized, as well as the randomized data from Europe, and laparoscopic hysterectomy was starting to diffuse at this time. But once robotic surgery was introduced, you can see even in 2010 there was really a paucity of data. This is a meta-analysis that really searched the world's literature. There were 8 observational studies, no prospective studies for cancer, where you can see under 600 cases of robotic surgery. When you compare robotic surgery to abdominal hysterectomy or laparotomy, I think not surprisingly, robotic surgery is associated with improved outcomes. When you compare robotic surgery to laparoscopic hysterectomy, really a very minimal benefit. Right? Whether 90 cc's lower blood loss is clinically meaningful, I think is questionable. And no difference in lymph node yields, which is a surrogate for oncologic quality in GYN. This is data from a large population database and an insurance carrier database looking at endometrial cancer from 2010 to 2008 to the first quarter of 2010. And you can see out of 2,500 patients who were on a minimally invasive procedure, already during this time period, 58% of those patients had underwent a robotic procedure. And again, this is when the world's literature on robotic hysterectomy for uterine cancer encompassed 600 reported cases. And by the first quarter of 2010, 61% of minimally invasive endometrial cancer surgeries were performed robotically. When you look at the morbidity profile, really no difference in any of the endpoints other than a slight decrease in medical complications, but no statistically significant difference in any intraoperative or surgical site complications, postoperatively rates of readmission, or perioperative mortality, which is very low within each group. When you look at cost, the cost of the robotic procedure was substantially greater than laparoscopic surgery. So you can see the median cost over $1,600 greater for robotic compared to laparoscopic hysterectomy, and that applies to all surgeons in all settings. So there's lots of talk about the learning curve. And when you look at this, certainly the cost goes down for more experienced robotic surgeons, but you see the same trend for more experienced laparoscopic surgeons. So when you compare apples to apples based on level of prior procedures and surgical experience, really no difference in cost. Now, from a marketing standpoint, certainly the big push by the industry was to develop robotic hysterectomy for benign indications. And when you look at the world's data, again, around the same time period, this is data from 2011, 2012, a Cochrane review, there were 2 prospective trials, essentially feasibility trials that looked at around 158 patients, that there was no improved effectiveness of robotic compared to laparoscopic surgery. And even in the meta-analyses of observational data, really not a clear benefit to robotic surgery over laparoscopic surgery. This is, again, the same large national insurance database, nearly 265,000 patients from the beginning of 2007 to 2010, the first quarter of 2010. And you can see that for benign indications, robotic hysterectomy made up nearly 10% of hysterectomies by the first quarter of 2010. And when you look at hospitals based on whether or not they performed a robotic hysterectomy, what you see in this graph, this is a graph of the breakdown of the type of hysterectomy performed in those centers that performed robotic surgery. You can see that these centers really started to perform robotic surgery. So by over 3 years after the adoption of the first robotic hysterectomy, over 20% of the cases were performed in a robotic manner. Now, what happened at those centers that did not perform robotic hysterectomy? Again, one of the big selling points is the robotic hysterectomy is really the only option for some women to undergo a minimally invasive surgery. And lo and behold, when you look at those hospitals not performing robotic surgery, you see a pretty substantial uptick in the number of laparoscopic hysterectomies performed. So those non-robotic surgeons, for a variety of reasons, likely started to perform robotic hysterectomy. When you look at the morbidity and mortality data, very similar to the cancer data, really no difference in the morbidity profile between robotic hysterectomy and laparoscopic hysterectomy. But when you look at the cost, there was a very substantial cost differential where robotic surgery was around $2,200 more costly, more expensive than laparoscopic hysterectomy. Now, when you look at costs, one of the common arguments or common concerns is that much of the cost is being driven by the instrumentation for robotic surgery, by the cost of the robotic platform, which is well over $1.5 million. And in this data set, we can get a specific breakdown of fixed costs due to equipment. And you can see, I think, as expected, that the fixed costs are certainly higher for robotic surgery, but you also have much higher variable costs. The variable costs, there was actually a greater differential in the variable costs. So this is operative time, disposable instrumentations, those sorts of things for robotic compared to laparoscopic hysterectomy. And again, when you model this and look specifically at surgeon experience, surgeon volume, do a variety of different modeling techniques and different patient scenarios, these data are largely unchanged. Now, what are the drivers of robotic surgery in gynecologic cancer and benign gynecologic procedures? Likely this is certainly multifactorial, and I think you've heard about a lot of these things in earlier talks today, traditional methods of data collection and the unwillingness of practitioners to wait for randomized controlled trials. You heard about Dr. Miller talking a little bit about the ideal recommendations for better ways for evidence to diffuse, reimbursement policy, and these patients and procedures are often covered just like a laparoscopic hysterectomy. A really lack of regulation. We heard a lot about the 510(k) process. That's the clearance mechanism for robotic procedures. And lastly, marketing has certainly played an important role. When I see patients in New York in a competitive marketplace, and patients will come in after they've tried out the robot at the local shopping center. So there's certainly this aspect of marketing to hospitals, to patients, as well as to physicians. This is data from one of my residents' projects, one of their research projects, where they just asked a simple question: what are our hospital websites saying about robotic gynecologic surgery? And you can see here, this is a breakdown of what they found on these websites. All of these claims along the bottom of the screen: less pain, shorter recovery, less scarring, less blood loss, less infection. Really very little data to back up any of these claims or assertions. And I think when you look further into the website, it's not infrequent that this is referred to as cutting edge technology. You really owe it to yourself to have a robotic hysterectomy. If you or your loved one needs a hysterectomy, this is what you would want. So again, certainly there are, again, I think as we've heard over and over, there are lots of non-medical reasons that are driving technologies like this. So we'll turn our attention a little bit to electric power morcellation. Again, this has been a subject that's been intensely in the headlines over the last several months. And again, this is all modifications of hysterectomy. I think when we think about pelvic surgery and hysterectomy, one of the challenges that we face is how to remove a parenchymal organ, oftentimes a very large parenchymal organ, through the small incisions that we use during minimally invasive surgery. And the classic technique for minimally invasive surgery is to remove the uterus through the vagina, so you don't need a large incision on the abdomen. There are lots of alternatives to this. The uterus can be morcellated either in the vagina through a scalpel. You can make a small incision on the abdominal cavity. Again, this often somewhat defeats the purpose of a minimally invasive surgery. Or more recently, what's been used is electric power morcellation. And you can see what a power morcellator is here. It's a small electromechanical device that's essentially introduced through the ports of a minimally invasive procedure. The end of this device is essentially a rotating blade that fragments the uterus or the parenchymal organ into smaller pieces. This is not something that's been new. This was first described and developed in 1993. A number of these devices have been approved by the FDA over the last 2 decades and diffused fairly rapidly into GYN practice. Now, why do we have a controversy surrounding morcellation? Really, all of this started by an article in the Wall Street Journal in December of 2013. And this was the case of a patient who was treated at a Boston hospital. The patient's an anesthesiologist, her husband's a cardiothoracic surgeon, and she underwent hysterectomy with morcellation for presumed uterine fibroids, benign tumors of the uterus, and she was found to have a uterine sarcoma, which is a very poor prognosis tumor. The tumor was a leiomyosarcoma that was disseminated at the time of surgery. And after this case, there was really widespread public awareness, a public campaign by the patient and her husband to ban all use of morcellation and really to try to get a handle on how we got to this point where we were using these devices where there was very little data that was available. And I think when this controversy started, and when you take a look at the literature there, I think there are really 3 main questions that arise. Really, number one, what's the incidence of organ injury at the time of the procedure? What's the risk of disseminating malignant disease? And third, what's the risk of disseminating benign disease? And I think when this case came up, if you did a literature review and tried to answer these questions, I think it's fairly safe to say that you probably cannot adequately answer any of these three questions at the end of this. So when you look at the rate of intra-abdominal organ injury, despite the fact that morcellators have been around the last 20 years, there's really one series that attempted to ascertain this. This is based on the MAUDE database. This is an FDA device database. It's voluntary collecting of data. And over the course of the last 2 decades, 55 complications were reported for morcellators. Most of these were organ injury at the time of the surgery, either bowel or GU injury. Again, this is voluntary reporting, so there's little impetus for physicians or hospitals to report to this database, so there's likely significant underreporting. Perhaps the most important question that came from this is what's the risk of an underlying cancer, specifically a sarcoma, at the time of morcellation. And the whole impetus to use morcellators is really based on literature that's many decades old that looked at the incidence of sarcomas that were associated with fibroids. This is data from the University of Southern California. It's a classic paper for OBGYN residents where they looked at 1,400 women who underwent hysterectomy for apparent fibroids. You can see the risk of leiomyosarcoma is low, less than 0.5%. So based on this, kind of classic teaching is that the risk of fibroid-associated cancers is extremely low. When this case started, there was really only one series that was published. This is data from a tertiary care center that looked at around 1,100 women who underwent morcellation for presumed fibroids. You can see that the risk of cancer at 1 in 545 or 0.2%, and the risk of variants of leiomyoma. So these are lesions with increased atypia, increased mitotic activity that don't meet the strict criteria for a sarcoma diagnosis, but these lesions can still recur, they can still metastasize and still spread. So they represent a real management challenge. So about 1% of either sarcomas or sarcoma-type variants. Now, for those women who do have a sarcoma that's disseminated, the prognosis is ominous. This is data looking at patients who underwent morcellation of a sarcoma. These patients were re-explored. They had apparent uterine confined disease at initial surgery, and at re-exploration, you can see 64% of patients already had metastatic disease at the time of re-exploration, and these patients have a poor long-term prognosis. This is a series of 56 women who had stage 1 or 2 leiomyosarcomas, stratified and matched based on morcellation versus non-morcellation, and you can see the hazard ratio for death in those women who underwent a morcellation of a sarcoma was 3.11. So these women are at substantial risk. The last concern that surrounds this is not only the risk of sarcoma, but for other pathology. And if you look at a morcellator specimen, this is essentially a pathologist's worst nightmare. You can see the specimen in this picture. It's multiple small fragments of tissue, disoriented, often very difficult to interpret at the time of the procedure and the pathologic evaluation. But in addition to sarcomas, these women are at risk for epithelial endometrial cancers, so garden variety endometrial cancers, which are much more common, and then a variety of benign diseases of the uterus that also can spread within the abdominal cavity and cause the need for further surgery, metastasis, and oftentimes further therapy. So all of this led to the FDA to start to take action. Again, there's very little data at this time. This was the first FDA advisory in April of 2014, basically warning providers and hospitals that patients were at risk for this and those who underwent power morcellation. There was a fairly swift reaction across the country. That most of the centers in Boston where this controversy started limited the use of morcellation. The major manufacturer of the morcellator, Johnson & Johnson, decided to remove their device and no longer produce it from the marketplace. And institutions started to rapidly implement policies. These are very diverse policies. And again, the concern is if women can't have morcellation, this may limit their potential to undergo a minimally invasive hysterectomy. The FDA conveyed an advisory committee meeting. This was in the summer of 2014, where they looked at 18 studies and they came up with an estimate of sarcoma of 1 in 352, and specifically leiomyosarcoma in 1 in 500 women. A limitation of this is none of these studies were really specific to morcellation. So this was a literature review of the risk of sarcomas in women who underwent a hysterectomy for fibroids. Now, the corollary to this is other groups. This is data from the American Association of Gynecologic Laparoscopy, also did a literature review, and their estimate was that sarcoma occurred in 1 in 7,400 women. So now we have these widely divergent estimates of 1 in 352 versus 1 in 7,400 women. So what is the prevalence of cancer? When you look at morcellation, this is, again, data from a large population-based data source of commercially insured patients, looking at the use of morcellation in women who underwent a minimally invasive hysterectomy. You can see, again, this data was really not even known how often we were using morcellation, but from 2006 to 2012, the incidence and use of morcellation was about 16%. And when you look at the pathology of these women, what you see, the estimates of uterine cancer are fairly in line with what the FDA reported from all women with sarcomas of 1 in 368. But you see a variety of other lesions, premalignant and invasive tumors that probably shouldn't be undergoing morcellation either. So cancers, either cervical cancer, fallopian tube, adnexal cancers, endometrial hyperplasia, which is a pre-invasive disease of the endometrium. When you look at all of these, there was actually a rate of 1 in 68 for abnormal pathology in women who underwent morcellation. And I think what you would expect, the women who were older tend to be at increased risk. So in those women who were over 60, the risk of cancer was 2.45% in those who underwent morcellation. So all of this data, as the story unfolded, led to a market recall of most of the commonly used power morcellators. Again, data is still limited at this point. And at this point, insurance companies also started to alter their reimbursement policy. So the first insurance company was Highmark Insurance in Delaware, which made the decision that they would no longer reimburse any hysterectomy that was performed with an electric power morcellator. So really, I think this is one of the first times, at least in GYN surgery, when you're seeing policy decisions really dictate practice. The FDA subsequently came with their third and last guidance that these morcellators should be contraindicated in women with suspected or known malignancies, and in peri or postmenopausal women who are candidates for other methods of en bloc tissue resection. So really, this is a large portion of those women who were undergoing hysterectomy with morcellation. Now, there are a number of modifications and things that have been promoted, different techniques about removing specimens in isolation bags. Again, all of these, one of the worries is many of these techniques are based on very little data, certainly raise concerns about the bag breaking. Some of these bags are made out of the same material as parachutes are made out of, but again, there's very little high quality prospective data looking at these devices. So despite the fact that morcellation, I think the pendulum really swung pretty rapidly to elimination of morcellation, really, are there any patients who would benefit from this technology? Again, I think we really risk the problem of throwing out the baby with the bathwater if we don't allow morcellation in some women. This is data from a decision analysis where you can look at the outcomes of a theoretic cohort of 10,000 women for morcellation versus abdominal hysterectomy and laparotomy. And what you can see is, I think as expected, total mortality was higher in the older women with morcellation compared to abdominal hysterectomy. But in the younger women, if you remove morcellation, mortality actually goes up. So those women, if 10,000 women underwent morcellation as opposed to a laparotomy, there would actually be 0.97 fewer deaths than compared to an abdominal hysterectomy. So I think certainly a word of caution on interpretation of data. And this is really the latest, where the FBI is investigating the device makers. More health insurance companies are threatening to curb use of morcellation. Aetna, which represents over 20 million covered lives, is currently reviewing their policy on morcellation. So with that, I will end. As far as conclusions, I think these controversies demonstrate, at least in GYN oncology, some of the difficulties with surgical innovation, and I think show you clearly some of the non-medical factors, including public opinion and how they can influence the conversation. Thank you.